So thank you everyone for coming in and joining us for our, this is our second session that ACRM is offering. I wanted to, hang on one second, I want to make sure I read the actual session so you make sure you made it to the right group. This is entitled Attention Employers, How to Avoid Your Employees Filing Class Action Suits Against Planned Fiduciaries. And this means the CEO, the CFO, the Chief Operating Officer, and the Chief Human Resource Officer at a minimum. We are honored to have the expertise of a leading PBM, data analytics firm, and consultant. I want to welcome Renzo Lazzotti and Mark Mincy of USRX Care, Robin Faust, My Catalyst, and Frank Stichter with Strategic Health Plan Consulting. For those of you who attended last year's conference, you may recognize Frank. Plus, he's also a world-famous actor. You may recognize my name. The two of us sat on a panel discussing the alignment between an employer and the consultant. And we will be referencing some of the discussion from last year in this panel. But to get us started, I wanted to make note, this is going to be a 45-minute recording, and then we will break for questions from the audience. As I mentioned, we'll do an update to the 2021 panel, but we're going to be incorporating the Consolidated Appropriations Act, better known as CAA, and Pharmacy Benefit Management, the PBM fiduciary. We will weave together the three themes of the Aspirational Healthcare Conference: alignment, patient-employer choice, and relationship. I'm going to start with Frank. Frank, can you please provide our audience a brief overview of what the CAA is? And I know you sent me a slide. Do you want me to?
Not quite yet.
Not quite yet. Okay, sounds good.
Okay. So hello, everybody. My name is Frank Stichter with Strategic Health Plan Consulting. I've been a traditional broker for about 30 years, and I saw the light after that and became an independent advisor, consultant, and actually compete against insurance companies. But the CAA, the Consolidated Appropriations Act, it's kind of been flying under the radar with a lot of employers. And understandably so. It hasn't gotten a lot of press, and there's a lot of aspects to it, but one of which is near and dear to my heart, and it's called, in effect, disclosure and transparency. So there's lots and lots. I mean, there's more revenue flowing out there from insurance companies and other vendors, PBMs and other vendors, more than you could possibly imagine. So the CAA, much like its retirement counterpart, that a law that was passed years ago, required disclosure and transparency from investment advisors, companies, and whatnot. So it's very similar to that in that, excuse me, all brokers, consultants, all service providers of any kind are to disclose both direct and indirect compensation or revenue sources and the amounts of revenue, and describe the various services that they perform. And just like its retirement counterpart, what it allows for, because there's so much under the table and undisclosed revenue, which I'll show you some of those sources in a minute, but it allows a plan sponsor, who in turn is a plan fiduciary, to negotiate, or at least understand, or perhaps not agree with, but understand all the revenue that brokers and consultants receive from insurance companies and other service providers. So it allows them, since they are plan fiduciaries, they're purchasing insurance with other people's money, namely contributions out of employees' paychecks, but it allows them to act as a responsible plan fiduciary in determining what's reasonable compensation for the services that are performed. The interesting thing is that, and I've held a couple seminars in the last few months with employers, and they are pretty oblivious to this whole thing. But one of the things that comes up is, well, how do I go about asking for this? And keep in mind, if you're an employer on this webinar, that the responsibility is on your back to request, document, and hopefully receive the contracts and the disclosure of all this compensation. It's not on those service providers to necessarily proactively give you this. This is a planned fiduciary responsibility, not necessarily one that falls on the back of, we'll just say, a broker. So there are a lot of different sources. Bill, maybe you can pull up that slide. And I've, as I said, I've worked for 3 very large regional agencies. I'm senior vice president and vice president of those. And I can tell you that lots of this stuff is undisclosed. In fact, Mark is going to be talking here about PBMs. And well, I have personal experience. We talked about this before. I mean, I've sat across from the president and CEO of a PBM just on rebates alone and asking me how much do I and do I want to receive, the insurance agency want to receive from that PBM. So the sources are various. They're typically commissions. If a broker or consultant is selling an insurance product, they're generally receiving a commission. Not always the case, but it could be for medical, dental, vision, life insurance, supplemental programs, all kinds of sources of commissions. They might also be charging a fee. Could be a per employee per month, could be monthly fee, an annual fee. The big one, though, that a lot of people are unaware of are what we refer to in our business as overrides. So as a broker or an insurance agency builds a book of business with you're going to hear BUCA probably a lot today, Blue Cross, United, Cigna, Aetna, those are the big ones. But as a broker builds a book of business, an incentive to sell more of that BUCA business or to retain the clients on their books, those insurance companies provide commission overrides. And I used one example. I won't name the insurance company, but if you had, let's just, for example, had $1 million of commissions coming in from an insurance company, which quite frankly is not very much for a big agency, especially a national one or a regional one. If you retained or renewed 90% of your business with them, they paid you a 40% commission override. Now, keep that in mind. If you had $1 million book and you retain 90% of it with that, you renew it, they're going to give you a $400,000 bonus. I mean, what broker is going to disrupt that revenue source? The status quo is very prevalent right now. So commission overrides are never disclosed on a 5500. Fees or rebates from a PBM, I mean, these can be sizable depending upon the PBM you're working with and what arrangement you have and how many clients, but these are not disclosed currently or previously. And there's a lot of contingent income or profit sharing arrangements whereby if I have a profitable book of business, meaning if my claims for that $1 million book of commissions is less than X, then I get part of the proceeds and the profits from having a favorable loss ratio. The other interesting thing is when this came out, when the CA came out, they gave no contractual template. There's no sample language. So it's all out there. We do have some, and I'm sure Akram has one, and I mean, there are some templates that can be used, but again, it's up to the plan sponsor, the plan fiduciary, to request, receive, and document this from all their service providers. So you've really, if you've done that, and negotiated, and that's kind of the big elephant in the room, is employers haven't had to negotiate much with the compensation that their broker or consultant receives. So now that it's been disclosed, you can say, hey, you're doing this, this, and this, but what I'm being charged or what you're receiving seems to be unreasonable comp for the services I'm getting. So, by at the end of the day, the employer's paying all this, contrary to what an insurance company might say that, that override doesn't come from you, the employer. It's like, well, where do you think that's coming from? It's falling out of trees? Of course, it's being paid by an employer one way or another. So
Frank,
that's kind of the 30,000-foot view.
Frank, this is an incredible overview that you've given us, and very detailed, granular. I really appreciate it. And I want to kind of roll the clocks back a little bit, because you did mention the 401k and the efforts we went through. That's when I started my career. 1985, I was with a early stage bank, which was owned by a large mutual fund company, which was owned by a large insurance company, and we'll call that Aetna. We, as a little bank, were in the early throes of setting up a 401k. And this is back at a time when organizations could put money into CDs or manage it themselves. Today, we would never even think about that. But I want to make that known, because this is kind of where we're sitting. We as employers have got to take charge of this. We've got to take responsibility for this, and we're the ones that are going to get penalized. And we're going to talk a little bit more about what those penalties are, because if you're a CEO, a CFO, Chief Operating Officer, Chief Human Resource Officer, among others, you better sit up straight and start listening to this stuff. So thank you for getting that out. Go ahead.
Yeah. No, I was just going to say, it's the same plan fiduciary for the retirement plan.
It absolutely is. Absolutely.
And, I've always wanted to, just real quick on an offbeat subject, but I've always wondered, why something hasn't occurred previously, because as a plan fiduciary, you are using other people's money to purchase this health insurance, but you don't know anything about the PPO discounts, because that's proprietary. You don't know anything about what providers are charging. And so, but you're using other people's money to buy this insurance, and you have no clue what you're paying for. And so I'm kind of surprised that, some youngster who's living in their parents' basement, who's paying, out of their paycheck for this insurance, saying, what's my employer doing here? I don't even know what I'm getting and what we're buying and how much it costs and whatnot. So it's time has come, and it's really good for employers, obviously, but it's good for all this to get on the table.
It absolutely is. And I remember when we were preparing for this session, and at least one of you mentioned that we may see at some point television ads from attorneys who are putting together class action suits against employers because they have not properly administrated or provided the fiduciary for these ERISA funds that we're talking about. And relative to the 401k, these dollar amounts are much more significant, much more. It's two different worlds. Let me bring in, I want to bring in both Renzo and Mark, and I'm going to take down your slide here. We can bring it back if we need to. But I want to bring in Renzo and Mark because part of the CAA is looking at drug spend. And I'm curious from your standpoint, I'll start with Renzo. What's the employer's concern regarding their PBM and drug spend as it relates to the CAA? You're on mute, Renzo.
Nickel in the jar.
One of the great things about these virtual panels.
So anyway, that was a good setup, Frank, and that's a great question, Bill. And the important thing is as it relates to CAA, right? Because employers should have a lot of concerns about their pharmacy spend. And as Frank said, it really is a black box, particularly in the PBM industry. And so this particular set of regulations, I would say, is maybe the first step, not the last step, in terms of driving transparency in the PBM space and in the carrier space. It is much needed because there is a lot of opacity there. And as was stated, the onus is on the employer to collect the information from their PBM, from their carrier, that they then need to turn around and submit and file with the federal government vis-a-vis the CMS website. Specifically in terms of PBM, one of the components of the regulation is particularly important in around transparency, and that is related to what they say no gag clauses. What does that mean? That means that you cannot have a contract with your PBM or your carrier or any other vendor that's touching your benefit that says that that you don't have access to your data and that you can't share it, right? Because the regulation requires not only that employers get access to their data, but they also have to submit it to the federal government, right? So if there are any contractual clauses in any PBM agreement, I'll focus there, they need to come out, right? So one of the things that frustrates us often, and clients that are looking maybe to make a change to their PBM, is they can't get access to their own claims. You know, I wonder, how is it that they're even paying their bill? To Frank's point, right? I mean, if you don't have access to the data, it's just a blank check, right? So no gag clauses is particularly important, and that speaks specifically to drugs and any other charges that may be reimbursed by the plan. And then there's information that needs to go on the ID cards in terms of deductibles and out-of-pocket maximums and websites and telephone numbers for access for members. You have to make widely available, publicly available, your network, which would include your pharmacy network, as well as other providers on the medical side, who's in and who's out. There are 6 reports, and I'll come back to that in a little bit, that are specific to pharmacy benefits that are required to be filed by December 27th. There's a comparison tool that needs to go up on website that starts with 500 specific products where pricing needs to be made available. And then that opens up to all items and services by 2024. And then there's some elements that touch on explanation of benefits and having access to know what the costs are going to be for a particular service before it happens, right? And that gets to the no surprises component and making sure that individuals know upfront exactly what it is going to be their cost before that cost is incurred, particularly if it's going to be an out-of-network charge. So there's a lot of things in here, and it's not just on the PBM side, but there's a lot of elements that are specifically targeted towards the PBM industry. I will say one thing, which is from our perspective unfortunate, because we believe in unadulterated transparency, no redactions, nothing to hide. There was another set of regulations that were promulgated in around the Transparency and Coverage Act. And with that, there was mention earlier, I think, about machine readable files. So there's 3 files that were supposed to be submitted. And my understanding is, not USRSCare, but others in the industry sued the government to remove that requirement. And so that requirement has actually been put on hold. Mm. So those machine readable files are no longer required to be submitted. And we're all waiting to see if and when that will come back. There still are 6 other files that need to be submitted by the end of the year. We can touch on that in just a little bit, but those machine readable files, which were critically important event from our perspective, that are put on hold, one of the things that would have become transparent with those machine readable files is spread pricing. That's the practice where the PBM will pay the pharmacy one price and then charge the client an upcharged price, a higher price. That was part of those machine readable files, and again, that's been put on hold. So it'll be interesting to see what happens there. But Bill, I'll turn it back over to you.
Yeah, thank you, Renzo. You have thrown an awful lot, similar to Frank, out on the table for us. I'm gonna pivot over to Mark. Mark, can you? And it may be a little redundant, but we might have to hear this more than once. But what type of reporting is going to be required by the PBM, the broker, and possibly others? Can you give us any sense of what kind of reporting you would anticipate?
Yeah, they have listed the reports, the top 50 most frequent brand drugs, the top 50 most costly drugs, top 50 drugs by spending increase, the RX totals, and then we get to the rebates. So that's going to be interesting. As Frank mentioned, sometimes there's sharing and sometimes there's retention of those rebates by the PBM or sharing of those rebates. So now the top 25 RX rebates and the rebates by therapeutic class, and then they're going to increase that number every preceding year. So I think and I'm anticipating they'll start to disclose a lot of this information gathered like they did with Medicare Part D, and that way you can see if your plan is coming up short, if the average rebate for a specific drug was $2,000 or $4,000 and you're receiving $1,000, now you know that you're not getting all of it, right?
Mark and Renzo, we'll be coming back to this in just a moment, but it sounds like all the smoke and mirrors is going to get suddenly blown away.
I think like I said, I think this is the first volley. Those that I've heard in other sessions that were part and parcel of authoring recognized that they did as much as they could with this opening salvo, and that we should all expect there's more to come. The one thing that's interesting on the rebate component, and one is for the top 25 drugs and the other is by therapeutic class, is in the reporting that is still required to be submitted by the end of this year, there's 3 sub-segments in that rebate report. One is the rebates retained by the PBM. Second is rebates retained by the plan issuer or carrier. And the third is any rebates that are passed to the member at the point of sale. So, that first one, that'll be enlightening if that, is now in the public realm. What percentage of rebates are kept by the PBM? There's a corollary section also, which is more like a white paper, if you will, where you have to define what a rebate is. Right. And, I think those of us that have been around this industry for a while know that that's very, very murky. Right. Right now, a rebate is whatever the PBM decides to call a rebate. Right. So all of that, in theory, is going to become in the public sphere come the end of the year. It'll be interesting to see what actually ends up in these documents.
Very interesting. Thank you both for sharing that. Want to bring Robin in. So we've heard reporting more than once, Robin, and as a data analytics leading provider out there, I'm curious from your standpoint, what are you seeing as a result of the CAA?
Thanks, Bill, and thanks, everyone. I think what we see is that there's really 4 key areas, and that is giving access to the provider negotiated rates and quality. As Renzo mentioned, it establishes reporting requirements for prescriptions that requires the plan sponsors to report prescription drug information to the Department of Labor, HSS, and Treasury. And those reporting requirements are pretty standard, which is good news from our perspective. And as Frank mentioned, the disclosure of direct and indirect compensation from all service providers, the parity in substance abuse and mental health benefits, as well. Plus, I mean, to me, the purpose is what we've already been hearing from others, and that's transparency, and that providers, you know, to provide insured members with more information to make more informed, cost-effective healthcare decisions, and so forth. And really, it's also gives the plan sponsor the ability to identify waste and work with their benefit consultants to develop strategy to reduce it. What we're seeing is a clamoring going on, if you will, related to the transparency and coverage ruling that requires the self-insured employer, unless they're grandfathered out, most of them are not, to comply with that ruling or deal with penalties. Now, most of the TPAs and BUCAs did release these machine-readable files July 1st, and now the TIC ruling for employers, it's January this year, and they have to open access to their employees, you know, to help make those informed decisions I mentioned earlier. And I don't know if you want me to go into a little bit more detail what we're seeing in those machine-readable files, because I know there was an article recently that said it's not for the faint of heart, and it is not. You have to have the capacity. You have to have the experience. I got a kick out of our developer who said for one of our clients on a BUCA that they were down to the billionth line. You have to connect data up in this section to this section to this section to this section. It also has to go into a member portal that the insured member can access to shop, you know, like you just said, those first 500 shoppable procedures that's required by these employers. We've been looking at the ability to push to these member portals, you know, the data that's needed to fill in gaps. I think one good piece of news is we've always run into, as others have, that through the BUCAs and TPAs, sometimes they're remiss in giving you type of bill, revenue codes, and MPI information. The MPI data is in there. However, I'll share with you, so far out of several BUCAs and several TPAs, one of the TPAs was not providing a required element, and that was the MPI number. There's a number in that field, but it's not MPI. And the reason we know is because we always can translate that MPI number through a national database into an actual name and address and things of that nature. So I think what's important here too is the ability to really make sure you are getting all the data that you need, that if you do choose some type of member portal, that they're not connected with a health plan. It's interesting sometimes when you go to search, all of a sudden you see just the hospitals, no other providers in the area to help with those informed choices. Being able to connect if you have multiple TPAs, being able to bring those machine-readable files in and push to where it needs to go. Preserving the data, that's actually something that's really important to the employers, that they have to demonstrate this, so they have that history and ongoing services, etc. So I hope that gives a little bit more insight from our perspective. That what you're saying, Bill, is so true. It's data, 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 and reporting, reporting, reporting.
Extremely helpful, Robin, and I guess as a former CFO, Chief Operating Officer, I mean I've got to hit the pause button here. It's this is an awful lot to unpack and be prepared for. So thank you for setting that up. I'm going to come back to Frank. Frank, I'm going to blend together a couple of questions with you, and one is playing off of our panel from last year. I'm curious what the benefits are of an employer retaining a consultant who is paid exclusively by the employer and does not accept any third-party commissions or overrides. I would think that suddenly a lot of these challenges of the CAA might go away in that situation. And but I'm going to pack on top of that question, Frank, another one, which is getting back to the title of this session, which is how to avoid your employees filing class action lawsuits against planned fiduciaries. And I'm curious what you might see or advice that you would have as a consultant to employers to maybe help them think through that. And you're on mute too. That's all right.
Thank you. Sorry about that. I think if an employer, to me, has to ask a question, and it's what's the value that a broker or consultant brings? Is it in the advice that they give, or is it in the products that they sell? So it's so misaligned right now because a broker is being paid by an insurance company to sell their product to an employer. It's like being a car salesman. I want to sell this Cadillac to this employer because the GM or Cadillac or Chevy, doesn't matter, they're going to pay me to sell this. So from a compensation perspective, it's very much misaligned. Commissions actually artificially inflate the premiums of every product because you're paying a commission on underwriting profits, state premium tax, and a lot of other elements that go into premiums. So not to be judgmental about what the compensation is that a broker receives. I mean, that's all going to come out or should come out with the CAA. But, if the employer would simply pay that as a fee instead of a commission, they would save approximately anywhere from 5 to 7% on their premiums. It's just, that's where the misalignment starts. And as I said before, to have a disgruntled employee who, comes after their employer because maybe they feel they're paying too much out of their paycheck, or they don't like the plan they have, or their deductible's too high. I'm a little surprised that planned fiduciaries haven't been challenged because of the lack of transparency in the insurance and provider world. It's all bass backwards, from a compensation perspective. It really is. So if an employer is going to seek services from a broker consultant, my belief is that employer should compensate that broker consultant directly, just like they do all their other professionals and other service providers.
Great.
Does that answer your question?
Yes. Very good. Thank you, Frank. That really is helpful. I'm going to come back to Renzo. I'm smiling a little bit because I'm trying to get my arms around this idea. PBM and fiduciary. I don't think I've ever heard those two terms weaved together. So,
right.
So help us understand what that all means.
Yes. Well, this is near and dear to our hearts here at US ArcScare. We came out of the health plan space, managing pharmacy risk for health plans. Plans with upwards of 2 million lives, Medicare, Medicaid, and commercial populations. When you're managing risk in a health plan, managing your own risk, there are no conflicts of interest, right? Everything is aligned. The formulary is in line with the guidelines, in line with the sourcing. Everything is aligned. Unfortunately, that's not the case in the PBM industry, which was one of the motivations that led us to get further into this space and to move specifically into the employer self-funded marketplace, because we saw a gap there. In terms of fiduciary is a term that is defined by ERISA. It also is pertinent in the financial services industry, as you know, but with respect to ERISA, there were three primary tenets. Number one is no conflicts of interest. Number two is only looking out for the best interest of the plan and the plan enrollees. And number three is all utilization and all financial information is in full view. So back to transparency. So those are the three tenets Your typical PBM and even on the carrier side, relationships and contracts will say that they're not a fiduciary, they're not obligated to act in a fiduciary manner, and if you ask them to do so, they can cancel the contract, right? So it's the exact opposite of what you would expect in a world where you have a planned fiduciary that's hiring vendors to manage their benefit. Selfishly from our perspective, we think the easiest way to become compliant with the CAA is to hire vendors that are willing to commit and uphold fiduciary standards. We'll see how that goes in the industry, but it kind of makes sense to us, right? If you're bringing a contractor in to work on your house, and there's a clause in the contract that says that they're not obligated to act in your best interest, so you're going to hire that individual to work on your house? Of course not. But that's not what happens, every day of the week in this industry. And it touches on everything. If you have conflicts of interest built into your into the vendor relationship in the PBM world, we see hidden, spread pricing, right? We see tremendous amounts of money flowing from drug manufacturers to PBMs. That's kind of like the broker analogy that Frank was talking about. The manufacturer is paying the PBM to sell their drugs, right? And it shouldn't be a surprise that the top growth of spend is in specialty, right? That's where the manufacturers are putting all their dollars. That's where they're throwing their R&D dollars. That's where they're throwing all the incentives at the PBMs, and it influences the treatment guidelines. It influences the formulary. It influences everything in a way that is often not in the best interest of the plan. So again, coming back to the CAA, it's refreshing and nice to see that there's recognition at the government level that there does need to be more transparency, and that as plan fiduciaries, those that hold that responsibility are going to be kept and held accountable to ensure and document and demonstrate that they're not overpaying for their services, whether it's a hospital admission or a medication that's dispensed from a specialty pharmacy.
Excellent. Very succinct in an area that Renzo, I think, is going to get a lot more attention. PBM fiduciary is probably long overdue. So thank you. Mark, I want to come over to you because a lot has been laid out on the table here. And two questions I'm going to pose to you are, number one, who's going to police all this, all these different ideas? And where do you see potentially class action suits originating? Because I got to imagine that in the PBM world, there's been a lot of things that have been done undercover. And for those in the audience, just to make note, the big three PBMs are CVS Caremark, which owns Aetna, Optum, and Express. Well, Optum is owned by United, and then Express Scripts owned by Cigna. They control at least 80% of the drug spend in the country. So I can't imagine what some of that reporting is going to look like, since I think a lot of that has been hidden behind different screens. But Mark, curious, who's going to police us, and what do you see as the class action suit that may come as a result of what's going on?
Yeah, good question. So the Department of Labor is actually the one that's doing the policing. Now, CMS is doing the information gathering since they have a portal ready to do that from their Part D experience. But the Department of Labor, the anticipated fines and the actual policing is supposed to be very significant, because it is the Department of Labor, and they're looking for more than slaps on the wrist. And I think one of the issues that could be, I think there's going to be many issues that could promulgate a class action lawsuit, but unfortunately, it's where it really impacts employees and their family members, because they don't have access to medications, because the plan is not set up properly because of the conflicts of interest, right? So you have one of the issues with the reporting, it does not require the profitability at a PBM specialty or mail order, which they, now about 70% of their revenue and profits really come from their specialty pharmacies and mail orders because they receive an extra discount. It's not defined as a rebate from pharma to feature their drugs on the formulary and to dispense those drugs with little to no prior auth, regulations or requirements. So you can imagine, the PBM recommending a $100,000, $200,000 product, and you have a high copay or deductible, and now you're unable to afford that, and the employee does some research on the CMS websites as they become available and the employer websites to see that everyone else is paying, or the range is where they're not using that drug. It's not in the top 50, but because the PBM profits, and that should be identified in the conflicts of interest when you're supposed to get all the conflicts of interest from all of your providers. So that should be recognized as a conflict of interest. Yet, where national guidelines, American College of Rheumatology may be recommending a $200 drug as first line agent, and the PBM is recommending a seventh line agent, according to the American College of Rheumatology, due to profitability and conflicts of interest. So now the plan sponsor has a responsibility to provide a fair product to their membership. So I think that's going to be one. And then just because of the overall waste that I think Frank and Renzo both identified, that you're paying potentially in your pharmacy 30% or more inflated cost that's going either to mostly to your PBM, but also back to your consultant or broker, and they're just cutting up the pie here. But it's inflated your cost, so their premium for the pharmacy component is 30% higher than it should be. And I think that hits everybody on a day-to-day basis. And so everyone that participates in the plan would be eligible for the class action lawsuit if they paid a premium.
Wow. Well, thank you, Mark. Hopefully executives that are listening to this are really taking note. Robin, I want to come back to you, and we are running up on the end of our time here, and I want to thank all of our panelists and the audience. We're going to be opening it up to questions in just a few minutes. But Robin, if you might be able to share some insights, what guidance could you offer to the audience regarding the selection and utilization of the data analytics tool to address these new set of requirements?
I really think the brokers and consultants have a really good opportunity to attract more business and retain clients by educating themselves about the CAA and the transparency and coverage ruling, which today is a great step, right? And I'm sure they're doing it elsewhere with other resources as well. The other is typically employers and consultants have been relying on their TPA for reporting. You've got to go beyond that. You need to find a qualified data analytics and reporting group. And also this helps in a way, if it's a third party, it helps preserve your history. It preserves your data. If you change TPA sources, so important. I think the other thing too is to, help consultants and the employer help your data analytics group to get the data that we need. Now, this ruling, this legislation has definitely opened up that transparency ability to get it. But as I mentioned earlier, if you don't know what you're doing, you may be thinking it's an NPI number and it's not. So how useful is that information? Evaluate if it's working or not. I think it's just important to start after you implement and do these things. Is it working? Are you really reducing your spend and getting better outcomes for your insured members? I want to add one other comment too, though, that I don't know that maybe another topic for another time, but I think the one missing element here is just because you build it and you provide these tools for your insured members, will they use it? So I think there's some thought that has to be given to how do you incent, how do you make sure, how do you promote that the insured members actually go and shop for more reasonable services and know from the pharmacy perspective what options and resources they have available to them. So with that, like I said, I think there's a lot of opportunity out there, and data is key, and you just have to make sure whoever you have in place, they really know what they're doing to be able to push to other tools you're using and give you that reporting that you need, because that's going to be critical for the compliance piece.
That's a great closing comment for this session, Robin. Thank you, because it is going to be somewhat of a tidal wave of lots of information and how it's accessible, and there's going to be an education not only with the employer but with the employee that's going to be necessary in order to evaluate this. Well, I want to thank Renzo and Mark from USRX Care. Thank you for unpacking this. I'll make a little sales pitch or advertisement from Akram's standpoint. We will be having a future webinar on PBM fiduciary, and you're going to be hearing that more and more often. So thank you for presenting that. Frank, I want to thank you, sir, because a lot of these ideas were initiated by you, and I want to thank for your thoughts. And my hat's off to you, because consultants need to follow down this pathway of dropping the commissions and the overrides and working, as I would call it, directly with their client and getting paid by their client. And very similar to how I, as a former CFO, would work with my investment banker, my commercial banker, my accountant, my attorney, etc. And Robin, thank you for your thoughts from an analytics standpoint, because that is going to be a critical piece of all of this, and not only with accessing the information, but also how to process or digest this. So thank you all, and we're going to open up to the audience for questions, and I really appreciate everybody's time.